In this section, we're going to take a look at the laxatives. These medications are very common in primary care. Laxatives are divided into 5 primary categories, which vary in terms of mechanism of action, potency, effect, indication, and cost. These 5 categories include bulk, stool softeners, osmotics, stimulants, and enemas. Some of the common ones that you might be aware of include cholates or ducostat sodium. Laxatives include metamucil, psyllium, osmotics, lactulose, magnesium hydroxide or milk of magnesia. The stimulants include Ducalax, biscoidal is the other name, and enemas such as fleet enema known as sodium phosphate. Indications: all classes are indicated for constipation, prophylaxis of constipation, polyethylene glycol or golightly, sodium phosphate, enema, magnesium citrates, all are used for surgical or procedural preparation. Saline expedites cleaning of the body's toxins or parasites. Psyllium is used for irritable bowel syndrome and diverticular disease. Polycarbophil for irritable bowel syndrome, diverticulosis, acute nonspecific diarrhea. Mineral oil enemas, relief of fecal impaction. Lactulose, hepatic encephalopathy, and libprostone, chronic idiopathic constipation, irritable bowel syndrome with constipation in adult women. What is the mechanism of action? All laxatives work by increasing fluid retention in the colon, resulting in bulkier and softer stools. By decreasing the absorption of luminal water through actions on the colonic mucosa, or by increasing intestinal motility. Expected results may take up from 5 minutes to several days. Stimulants or irritant laxative increased peristalsis via several mechanisms. Depending on the subclass, stimulants have a direct action on intestinal mucosa or on the nerve plexus. Biscoidal stimulates sensory nerves in the intestinal mucosa and increases intestinal chloride secretion. Anthraquinone derivatives such as Cascara, Senna, Casapranol primarily stimulate colonic intramural nerve plexus. Senna is protected from small intestinal absorption by its glucose molecules. Colonic bacteria cleave the glucose molecules, releasing active rhinophrones and producing an action that is specific to the colon. Senna alters the permeability of colon cell walls, resulting in increased fluid accumulation in the colon. Stool softeners lower surface tension of the fecal mass and inhibit fluid and electrolyte reabsorption. The bulk laxatives are non-digestible and non-absorbable. They swell in water to form a viscous solution or gel that absorbs water and expands, increasing both bulk and moisture content of the stool. Increased bulk stimulates peristalsis, and the absorbed water softens the stool. Bulk laxatives also stimulate colonic bacterial growth that increases the weight of the stool and stretches the intestinal wall, further stimulating peristalsis. Again, stool softeners act to soften stool by lowering surface tension, allowing fecal mass to be penetrated in the intestinal fluids. They also inhibit fluid and electrolyte reabsorption by the intestine. Cholates or ducostat sodium is an anionic surfactant that lowers the surface tension of stool to allow mixing of aqueous and fatty substances, which softens the stool and permits for easier defecation. Osmotic laxatives are largely non-absorbable sugars, although small amounts may be absorbed. Bacteria mobilize these agents into lactic acid, formic acid, acetic acid, and carbon dioxide, which act via osmosis. This means that they are present in solution in higher concentrations in the bowel, causing water to move from the tissue into the bowel to equalize the osmotic pressure. The increased bulk increases colonic peristalsis. Most are disaccharides. Lactulose is a semisynthetic disaccharide of fructose and galactose. Sorbitol is a non-absorbable sugar. However, glycerin is a naturally occurring trivalent alcohol suppository that acts via hyperosmotic action and through local irritation and lubrication. The American College of Gastroenterology Task Force has named osmotic laxatives as among the most effective types. Saline laxatives attract and retain water in the bowel, thereby increasing intraluminal pressure. Saline laxatives produce an osmotic effect, drawing water into the intestinal lumen of the small intestines and the colon and inducing contractions. Magnesium hydroxide also stimulates the release of cholecystokinin, which increases intestinal secretion and stimulates peristalsis and transit. Enemas work primarily by inducing evacuation as a response to colonic distension and via lavage. They create a barrier between the feces and the colon wall that prevents colonic reabsorption of fecal fluid, thus softening the stool. The lubricant effect also eases the passage of feces through the intestine. Oil retention mineral enemas also work by lubricating the rectum and the colon. Soap suds enemas provide an irritant action. For the evidence-based recommendations, two drugs, polyethylene glycol and lactulose, are rated as signifying benefit as demonstrated by 2 or more randomized controlled trials conducted with appropriate methodology. Facilium is likely to be beneficial. Polyethylene glycols are effective. Lactulose is likely to be beneficial. First-line treatment with unproven benefit includes lifestyle changes, paraffin, seed oils, magnesium salts, phosphate enemas, sodium citrate enemas, biscoidal, ducostat, glycerol, glycerin suppositories, and senna. For the cardinal points of treatment, non-pharmacological treatment includes fluids and fiber. Treat the underlying cause of constipation first, if possible. Start treatment for constipation immediately if it is causing significant discomfort. By understanding the underlying cause of the constipation, you will be better prepared to choose the class of laxative that is most likely to be successful. For example, constipation caused by diseases such as hypothyroidism should be resolved with treatment for hypothyroidism. For the non-pharmacological treatments, these non-pharmacological measures are cost-effective and do not produce the complications associated with laxative use. These measures should be used in all patients with constipation, regardless of whether a medication is prescribed. No medication is adequate replacement for these measures. Non-pharmacological management for chronic constipation is encouraged for all ages, especially the young and the old. In the absence of disease, adequate colonic movements can be achieved by a regimen based on 4 components. First, adequate fluids are crucial for both for laxatives to work and to prevent constipation, with 1,500 mL per day minimum essential for maintaining normal bowel activity. Adequate fluids act by keeping fluid in the feces as it passes through the colon. This maintains the bulk of the feces and allows for normal transit. Fluids that are diuretics, such as those that contain caffeine, do not work as well as to keep the water in the feces. Flavored waters are often an acceptable substitute for plain water. However, data are lacking to support that an increase in fluids to greater than 1,500 mL per day is effective in alleviating constipation. Second, a high-fiber diet is important. Adults should have a daily intake of 20 to 35 grams of fiber. A child should receive 1 gram per year of age plus 5 grams per day after 2 years of age. This fiber is best obtained from high roughage foods like bran or vegetables and fruits. Bran is the outer coating of various grains. The two most commonly found grains are wheat bran and oat bran, which have large amounts of fiber. Other whole grain, unpolished grains, and rice have the outer coating still on. They have good amounts of fiber and may be easier to tolerate than concentrated bran. Sudden increases in fiber in the diet can cause bloating and gas. High fiber diet is better tolerated if the change is made gradually. Enough fiber can be obtained through the regular use of bran slurry. Start with 1 teaspoon a day and work up to 3 tablespoons. Start with 1 tablespoon per day and work up to 3 tablespoons twice a day as needed. It can be mixed with cereal or other foods. Make sure the patient continues to drink enough fluids. Third, patients should establish and maintain a regular exercise schedule. Any type of activity is helpful. Simply walking briskly every day facilitates digestion and keeps muscles of the body better toned. Fourth, a regular toileting schedule should be established. This includes going to the toilet at the same time of each day, 15 to 45 minutes after a meal. Patients should allow for 10 to 15 minutes on the toilet without interruption, stress, or the need to hurry. Patients should not ignore or postpone the urge to defecate. Fluids, fiber, and exercise, which help most people, are not applicable to the very aged, the frail elderly, and those wheelchair or bedbound. Other individuals with CHF are unable to tolerate these mechanisms. It's essential for clinicians to know their patients and assess what is reasonable for them to do. Pharmacologic treatment may be added if non-pharmacological treatment is not sufficient or when immediate or thorough cleansing is indicated. Selection is based on matching the patient's characteristics to the effects of the different categories of laxatives. Important factors should be considered include the cause of constipation, long or short-term use, severity of constipation, age of the patient, oral food and fluid intake, and prior laxative use. Polyethylene glycol and lactulose are recognized as highly effective. One important decision involves the medication formulation. Remedies are available as oral agents, rectal suppositories, and enemas. Oral formulations may come in tablet, capsule, syrup, powder, or liquid form. Some forms are dissolved in water. Oral treatment is selected for long-term use. It's essential for the clinician to find a formulation that the patient is willing and able to tolerate on a long-term basis. Oral medications also can be used on a short-term basis for severe constipation. Rectal suppositories and enemas should be used only for short-term management because irritation of the rectum can occur with long-term use. What is the management of these laxatives? Bulk laxatives are the most commonly used first-line agents used to prevent or treat mild short-term constipation. They're especially helpful for long-term use because they have a good safety profile. The patient with severe constipation may need to have a more potent laxative, especially at first. These products are available as powder that is mixed with water. Some form a gritty residue that is unpalatable. Some also are provided as wafers or tablets. Patients likely to benefit from bulk-forming laxatives include postpartum, elderly, and debilitated patients. Patients who eat a small quantity of food and those who have a low level of mobility are also likely to benefit. However, these agents can be dangerous for patients with poor fluid intake. They can be used to wean patients from long-term stimulant use laxatives. Bulk laxatives may reduce the risk of colon cancer. Psyllium lowers serum cholesterol by binding bile salts in the intestine. Stool softeners or fecal softeners are mild-acting and frequently are used for long-term treatment and prevention of constipation produced by a delay in rectal emptying. They are also useful when it's important to reduce straining of stool, as in patients with a hernia or cardiovascular disease, during postpartum or after rectal surgery. Fecal softeners can be helpful in elderly patients who are unable to drink adequate fluids, or bulk laxatives to be effective, and if their constipation is not opioid or drug-induced. Mineral oil now is regarded as not safe for oral ingestion. It is not recommended. Lipid pneumonitis may result if oral ingestion and aspiration of mineral oil occurs, especially when the patient reclines. Osmotic laxatives are used. They've been greatly increased in the recent years. They're used for short and long-term constipation and for bowel cleansing. They're especially useful for moderate to severe chronic constipation. These agents are preferred over stimulant and saline laxatives because they have a better safety profile but are not as potent. One drawback is their costs. Only Libraprostone requires a prescription. Sorbitol is used for short-term treatment of constipation. It is also mixed with activated charcoal in the management of poisoning or drug overdose. Lactulose is used to treat constipation. It is useful for reducing urea production in the colon, thus lowering blood ammonia levels in patients with portal systemic encephalopathy. It comes in a thick syrup that many patients find unpalatable. Polyethylene glycol comes in two forms: Miralax powder for chronic constipation and Go Lightly for bowel cleansing before a procedure. Miralax comes as a powder that dissolves in water and is tasteless and non-gritty. Because polyethylene glycol is an isotonic solution, dehydration does not occur. Glycerin suppositories aid rectal evacuation. They are useful in bowel retraining programs and for reestablishing normal function in those who are laxative dependent. They may be used as an occasional basis in the management of chronic constipation. They do not have a powerful osmotic effect. Libraprostone is a product that relies on activating the local chloride channels that enhance intestinal fluid secretion without altering sodium and potassium concentrations in the serum. Increased intestinal fluid secretions increase the motility in the intestine, thereby promoting the passage of stool and elevating symptoms associated with chronic idiopathic constipation. For stimulants, they represent the most potent effective class of laxatives. They are recommended for short-term treatment but may be used on an occasional basis in patients with chronic constipation. They should be used only after other methods have failed. Stimulants are also used to cleanse the bowel in preparation for endoscopy, exams, X-ray studies, or surgery. Biscoidal suppositories are used to cleanse the colon in pregnant women before delivery. Saline laxatives are also potent laxatives. They are used to cleanse the bowel in preparation for endoscopic exams, X-ray studies, or surgery. Saline laxatives are used to hasten evacuation of worms after administration of antiemetics and to hasten elimination of toxic material after ingestion of poison. They are the laxative of choice for securing a stool sample. Milk of magnesia may be used on an occasional basis for patients with chronic constipation. If milk of magnesia alone is ineffective, milk of magnesia with cascara may be given with caution. Milk of magnesia is a very popular over-the-counter laxative and is a cause of LAS. The magnesium laxatives have a significant risk for adverse reactions with long-term use. They may cause an accumulation of magnesium, which may be a problem in patients with renal insufficiency. And finally, enemas are used for short-term constipation when the patient is being started on a bowel regimen. They are also used to prevent discomfort and tearing or lacerations of hemorrhoids or fissures. The enema may be necessary to soften stool after abdominal or rectal surgery. Repeated enemas can cause rectal irritation. Fleet enemas contain only small amounts of liquid to fill the rectum. Oil enemas are very helpful for softening hard stool. Enemas that consist of soap suds or tap water use more liquid and go farther up the colon. These types may be effective in case of high impaction, but they may put the patient at risk for electrolyte imbalances. Pulsed irrigation enhanced evacuation is used to treat fecal impaction in children and adults that otherwise may require operative disimpaction. Normal saline or ear enemas are used under ultrasound guidance for the non-operative management of ileocolic intussusception. They may be used for treatment of acute fecal impaction if phosphate-containing enemas are contraindicated. So how do we monitor these patients? Short-term monitor for effectiveness. This includes the ability to pass stool and the resolution of symptoms such as abdominal pain, gastric distension, and excessive straining of stool. Long-term use, all laxatives promote fluid loss. Monitor fluid and electrolytes. Monitor for the effects of laxatives on other medications. Reevaluate the use of laxatives according to the status and variability of other comorbid conditions or whether surgical intervention may alleviate the need for laxative use. Again, short-term constipation, whether occasional or caused by external factors, is treated with short-acting laxatives. Another short-term use for laxative involves preparation for surgery or another procedure. Mild short-term constipation can be treated with bulk laxatives or a saline agent such as milk and magnesia. If the patient is severely constipated or has not responded to increased fiber intake, he or she might need an enema or one of the more potent laxatives. Saline laxatives such as milk and magnesia are suggested as second-line treatment for the AGA, American Gastro Association. Enemas are useful when the patient has stool in the rectum but unable to push it out. If the patient is impacted, he or she must be manually disimpacted before any laxative is used. Stimulant laxatives are used for constipation that occur higher in the colon, should be considered third-line agents. If the patient has chronic constipation with short-term exacerbation, long-term management will be necessary. For long-term management, choose a laxative based on the patient's characteristic and then initiate treatment. If the patient has mild constipation, simple long-term treatment is adequate. If the patient has severe constipation, short-term treatment should be instituted with long-term program to be started. The patient must continue a regimen for at least a week before its effectiveness is evaluated and increase the dose as necessary. If first-line treatment is not effective, consider changing laxatives or adding a second laxative. Change to more potent category, but use caution if adding a second laxative. Do not use two laxatives from the same category. Bulk and stool softeners can be combined safely with other laxatives. However, this approach will not be needed if the patient is placed on osmotic laxatives because these also soften stools. Stimulants, saline, and enemas may be given as needed for short-term problems. Monitor the frequency of their use. If they are needed often, this means that the long-term plan needs adjustment. Stimulant, saline, and osmotic laxatives should be combined with each other. Should not be combined with each other because of the increased risk of adverse reactions. Biofeedback has been shown to be effective in the management of chronic idiopathic constipation. For those patients with chronic laxative abuse, many patients already have used pharmacological treatment and have developed catarrhatic colons from LAS. These patients should be weaned from their stimulant and saline laxatives and placed on safer long-term laxatives. Long-term management should be initiated with a bulk or stool softener for mild constipation. Usually, however, these patients need a stronger laxative such as an osmotic. Gradually decrease use of the stimulant or saline laxative as tolerated. Patient education is crucial for success. For the bulk laxatives, they are most commonly used as first-line agents to prevent the mild short-term constipation. They are especially helpful in long-term use because they have a good safety profile. A patient with severe constipation may need a more potent laxative, especially at first. The products are available as powder that is mixed with water. Some form a gritty residue that is unpalatable. Some are also provided as wafers or tablets. Patients likely to benefit from bulk-forming laxatives include postpartum, elderly, and debilitated patients. Patients who eat small quantity of food and those who have low levels of mobility are also likely to benefit. However, these agents can be dangerous for patients with poor fluid intake. They can be used to wean patients from long-term stimulant laxatives. The bulk laxative may reduce the risk of colon cancer. Psyllium lowers serum cholesterol by binding bile salts in the intestine. It may be used for those patients with high cholesterol. Again, the stool softeners are mild acting and frequently used for long-term treatment and prevention of constipation, produced in a delay in rectal emptying. Mineral oil now is regarded as not safe for oral indigestion and is not recommended. Again, lipid pneumonitis may result from oral ingestion and aspiration. The osmotic laxatives greatly increased in the last few years. They use short-term and long-term constipation and for bowel cleansing. Lactulose used to treat constipation, also reducing urea production in the colon and lowering blood ammonia levels in patients with portal systemic encephalopathy. You'll see this a lot in patients, renal failure patients. For patient variables, geriatric patients, constipation increases with age. As many as 30% of healthy older persons regularly use laxatives. Laxatives are second only to analgesics as the over-the-counter drugs most commonly used by elderly patients. Older adults are more susceptible to dehydration and electrolyte imbalance caused by these laxatives than are your younger patients. Because of other drugs taken concurrently may be a frequent cause of constipation in elderly. A frequent review of all drugs is essential. For pediatric patients, constipation in children may have many causes. Contributing factors include emotional, dietary, and environmental changes. Dosage adjustments are indicated for specific drugs. Magnesium salts and phosphate enemas can cause serious metabolic disturbances in infants and young children. Administer these with caution. Do not administer enemas to children younger than 2 years of age. Infants who receive lactulose may develop hyponatremia and dehydration. For pregnancy and lactation, constipation is common during pregnancy and is thought to be due to an increase in circulatory progesterone. This is compounded by the fact that vitamins, iron, and calcium taken during pregnancy tend to be constipating as well. Category B drugs include lactulose, psyllium, magnesium salts. Category A/C varies by manufacturer. Category C, methylcellulose, calcium polycarbophil, casanthrol, cascara sagrada, ducostat sodium, ducosate calcium, mineral oil, senna. For those in pregnancy that it's contraindicated, castor oil during pregnancy. It's an irritant. Its irritant effect may induce preterm labor. Improper use of saline catharetics can lead to dangerous electrolyte imbalances. Bulk-forming laxatives or stool softeners are preferred. Although the absorption is limited, laxatives may be excreted in breast milk. For race and gender, constipation is more frequent among women and non-whites than among men and whites. Social cultural individuals with low income and low level of education are at increased risk for constipation. This may be due to poor diets. For patient education, patients and parents or parents may have to be educated about what constitutes a normal bowel movement. Non-pharmacological measures should be reviewed. Specific instructions should be written on a prescription pad, and information on high-fiber food should be provided to the patient. So looking at the other side of the spectrum, let's start talking about antidiarrheals. These include the opiate and opioid derivatives, anti-secretory agents, absorbents, and the oral rehydration solutions such as electrolyte solutions. The guidelines put forth by the American Gastroenterological Association emphasizes comprehensive evaluation of a patient before treatment is provided. Patient's history is important for the diagnosis. Similar illness in contacts points to an infection. Ingestion of improperly prepared or stored food suggests infection or bacterial toxins. Exposure to impure water suggests parasites. Travel abroad exposes patients to infections that are characteristic of the local area. Antibiotic use points to Clostridium difficile. The critical laboratory tests involve sending the stool for fecal leukocytes, routine stool culture, and C. diff. Obtain over in parasites if the patient has had diarrhea for longer than 10 days, has traveled to an endemic region, is experienced a community water-borne outbreak, or has HIV virus, or is a homosexual male. If suspicion involves a specific infectious cause, focused stool testing can be ordered, such as Giardia, Norwalk virus, and Cryptosporidium. Antidiarrheal agents are used as temporary adjunct therapy in the management of acute nonspecific diarrhea and functional chronic diarrhea. Acute episodes of diarrhea are usually benign and self-limiting, by definition lasting less than 2 weeks and usually lasting only 1 to 2 days. Diarrhea in pregnant women and in infants can have serious complications or consequences, and the patient may need to be referred. If diarrhea persists for longer than 72 hours or if gross blood is present in the stool, the patient should be evaluated further. Diarrhea should always be evaluated before pharmacological treatment is begun. Diarrhea is a symptom, so therapy should be targeted at treatment of the underlying cause. Many antidiarrheal agents are now available over the counter and therefore may often be overused. Opioid agents may prolong acute infectious diarrhea, leading to potentially serious complications and consequences. Antidiarrheals should never be used for longer than 48 hours without supervision of a healthcare provider. Short-term use generally is considered safe but should not serve as a substitute for determining the cause of the diarrhea. The American Gastroenterological Association guidelines form the basis for recommendations, and you can look at online at that. So, mechanism of action of these medications: the opioid antidiarrheal agents act on the smooth muscle of the intestinal tract to slow GI motility and propulsion. Slow transit time of intestinal contents allows more fluid to be absorbed from the stool, thereby decreasing fecal volume, as well as the fluid and electrolyte loss. Little or no analgesic activity is noted. The opioids, except loperamide hydrochloride, may be habit-forming. Atropine sulfate is added to some formulations to discourage abuse and deliberate overdoses. Absorbents act by reducing intestinal motility and by absorbing fluid. If infectious diarrhea, they bind bacteria and toxins in the GI tract. For anti-secretory medication, 2 portions of this succinylate bismuths and subciliates provide the anti-secretory effect. The bismuth portion may exert antimicrobial effects. Cardinal points of treatment: rehydration and opioids are more effective and more palatable than absorbents, but have a greater number of side effects. The pharmacological treatment, empirical treatment of diarrhea is appropriate in the, when initial treatment before diagnostic testing is complete, diarrhea without a diagnosis, and diarrhea with diagnosis but no cure. Acute diarrhea. Acute diarrhea is usually mild and self-limited. Non-pharmacological measures, especially bowel rest and adequate hydration, rest, reassurance, and electrolyte replacement is helpful. Oral rehydration with electrolyte solutions such as Gatorade or Pedialyte is recommended in moderate to severe cases. Cola or ginger ale may be sufficient in mild cases. If the patient is not able to replace liquids as fast as they are lost, further treatment is needed to prevent dehydration. Children and frail patients with severe diarrhea may need antidiarrheals or IV rehydration, which can be accomplished in the ED without the need for hospitalization. Oral rehydration should be performed rapidly over 3 to 4 hours. Continue oral hydration to compensate for ongoing losses. The World Health Organization guidelines has information on this. An unrestricted diet is recommended as soon as dehydration is corrected. If infants are breastfed, nursing should be continued. If infant is formula fed, continue the current formula. Do not dilute or use a special formula. Treatment of patients with acute diarrhea with the use of antidiarrheals can prolong infection and should be avoided if possible. If patients find the diarrhea significantly inconvenient, they may be given antidiarrheals on a limited basis. They may be used safely in patients with acute, mild to moderate diarrhea. Their main use is to ensure patient comfort. Do not use these products in patients with bloody diarrhea, high fever, or systemic toxicity because these conditions may worsen the disease. Discontinue if not effective and investigate the reason for the diarrhea. Used on a short-term basis, they are safe and effective for patient relief, allowing the patient to function in their usual activities and avoid distressing episodes of incontinence. Patients with acute inflammatory diarrhea that does not improve within a few days may require antibiotic therapy. C. diff is treated with Flagyl 500 milligrams 3 times a day for 10 days for mild to moderate infection. This is oral Flagyl. More severe infection is treated with vancomycin 125 milligrams 4 times a day for 10 days. These medications are not effective if given through IV course. For chronic diarrhea, once the source of the chronic diarrhea has been optimally treated, antidiarrheals may be used as needed to control symptoms and prevent dehydration. Opioids are generally safe and effective if used by directed. Fiber products may also help control chronic diarrhea. For the opioids and opioid derivatives, they decrease motility, stool number, and reduce fecal urgency. They are best used for chronic diarrhea. For the absorbents, bismuth reduces the symptoms through its anti-inflammatory and antibacterial properties and decreases nausea and vomiting. It's best used for acute diarrhea. How to monitor these patients: monitor the number and character of stools and have the patient keep a record as needed. Monitor hydration status, fluid and electrolyte loss, hypotension, and signs of dehydration. Observe for signs of toxicity. It depends on the specific drug. For acute diarrhea, this should improve within 48 hours once treatment is initiated. For chronic diarrhea, it should improve within 10 days. Patient variables: for geriatric patients, fecal impaction associated with the use of absorbents is more common in debilitated geriatric patients. Diarrhea can be caused by leakage of stool around the impaction. For pediatric patients, antidiarrheals are not recommended in young children. Opioids are contraindicated in children younger than 2 years. Bismuth and atopulgate are not recommended for children younger than 3 years of age. In patients who are pregnant and lactating, atopulgate is a category B. Category C includes loperamide, diphenolxylate, atropine, bismuth. However, that is considered category D in the 3rd trimester. Diphenolxylate and atropine are excreted in the breast milk. And patient education, supportive therapy includes rest, hydration, and appropriate diet. Is recommended for the first-line treatment for acute diarrhea. When safety precautions, the patient should use safety precautions in driving or operating machinery that requires alertness because the drugs may produce drowsiness or dizziness. When using opioid agents, avoid alcohol and other CNS depressants. They should not exceed the prescribed dose. Antidiarrheal agents should not be used for self-medication for longer than 48 hours. If the diarrhea is not controlled within 40 hours or a fever develops, the patient should be seen by their provider. So now we'll move on to antiemetics, another common symptom seen in practice. These drugs include the antidopaminergic, such as the phenothiazines, the benzamides. The anticholinergics includes the antihistamines and others, such as scopolamine, and the serotonin 5-HT3 receptor antagonists. In all cases of nausea and vomiting or vertigo, the underlying cause should be established because nausea and vomiting are symptoms and are only manifestations of pathophysiological problems for which further exploration and workup is needed. Severe nausea and vomiting may be the presenting symptom of an underlying condition such as brain tumor, intestinal obstruction, or appendicitis, and the use of antiemetic medications may slow the diagnosis. Mechanism of actions: metoclopramide prevents stimulation of the CTZ, chemoreceptor trigger zone, by antagonizing central and peripheral dopamine receptors and at higher doses serotonin receptors. This accelerates gastric emptying by enhancing the effect of acetylcholine in the upper GI tract. Trimethylbenzamide mechanism is unknown. It's thought to be mediated through the CTZ, and it directs impulses to the CTV. The direct impulses to the CTV are not inhibited. Antiemetics act on the VC in the medulla through the 4 different sources of stimuli inputs. Antidopaminergics, phenothiazines block D2 dopamine receptors in the CTZ as well as other areas of the brain. They also have anticholinergic and antihistamine effects. Examples of these are antidopaminergic agents such as metoclopramide, which prevents stimulation of the CTZ by antagonizing central and peripheral dopamine receptors and at higher doses serotonin receptors. It also accelerates the gastric emptying by enhancing the effect of acetylcholine. The trimethylbenzamide, the precise mechanism of action is unknown, but it's thought to be mediated through the TGZ. However, direct impulses to the VC are not inhibited. The anticholinergics have antiemetics, anticholinergic and antihistaminic properties. These antihistamines reduce the sensitivity of the labyrinthine apparatus. This may be mediated through nerve pathways to the VC from the CTZ. peripheral nerve pathways or other CNS centers. These drugs have a suppression action on hyperstimulated labyrinthine function. The precise mode of action is not known. Inhibiting of the vestibular input to the CNS results in inhibition of the vomiting reflex. For scopolamine, it's commonly used. It's an anticholinergic that causes inhibition of the vestibular input to the CNS, which results in inhibition of the vomiting reflex. Scopolamine also may have a direct action on the VC within the reticular formation of the brainstem. NK1 receptor antagonists, it has a selective high affinity antagonist of human substance P neurokinin or NK1 receptors, and is the active ingredient of Amend that recently has been approved by the FDA for the prevention of chemotherapy-induced nausea and vomiting. Early studies led to the development of a nanoparticle formulation that can be used to enhance exposure and minimize food effects. This improves the quality of life without increasing adverse effects. This is very exciting that we can find another agent that may be effective for chemotherapy-induced nausea and vomiting. For the serotonin 5-HT3 receptor antagonists, these are selective inhibitors of type 3 serotonin 5-HT3 receptors that exhibit antiemetic activity. They work peripherally in the intestinal wall by blocking 5-HT3 release from enterochromaffin cells, and centrally by blocking 5-HT3 receptors in the CTZ. Current data suggests that the serotonin receptors play a major role in acute emesis, but only a minor role in delayed nausea and vomiting. Examples of 5-HT3 receptor antagonists include Zofran, Delestrone, Grancesitrone, and Palancitrone, which are available only in IV formulation. Again, the NK1 receptor agonists, selective affinity antagonists of human substance P neurokinin 1 NK1 receptors, and the active ingredient of Emend. So cardinal points of treatment: motion sickness, usually treated with anticholinergics. Chemotherapy-induced vomiting, the 5-HT3 receptor antagonist, metoclopramide or corticosteroids. Vomiting from other causes, antidopaminergic agents or metoclopramide. Vomiting can be divided into two types: acute vomiting and anticipated vomiting, precipitated by predicted cause such as motion sickness or chemotherapy. Non-pharmacological treatment for acute vomiting. Most causes of acute vomiting are self-limiting and require no specific treatment. The focus of treatment for acute nausea and vomiting is to replace fluids and electrolytes in order to prevent dehydration. General supportive treatment for nausea and vomiting consists of a diet of clear liquids and small quantities of dry foods as tolerated. For pharmacological treatment of acute vomiting, if the patient intake is disproportionate with fluid loss, antiemetics should be given. Antiemetics also may be given as a comfort measure. If nausea without vomiting is predominant, an oral antiemetic should be adequate. If, however, nausea is accompanied by vomiting, the use of rectal suppositories may be necessary. If the patient is experiencing predominantly nausea, oral antiemetic may be effective. Rectal suppositories are effective for short-term use for acute nausea and vomiting, but cause rectal irritation with regular use. Once the vomiting is under control, the patient may be switched to oral antiemetics to prevent reoccurrence of vomiting until the cause of the vomiting has been resolved. If vomiting is not controlled, dehydration may occur with associated hypokalemia and metabolic alkalosis. Patients may be treated with IV fluids containing potassium and other medications and fluid replacement in a hospital or emergency department setting. Pharmacological treatment for anticipated vomiting. In many situations, nausea and vomiting may be anticipated. These situations involve motion sickness or chemotherapy. Pre-medicating the patient with an antiemetic may be necessary in order for the patient to receive full therapy. This is the current standard of care. You should also monitor CBC in a patient who is undergoing chemotherapy to ensure the white blood cell count and platelets are adequate. Antidopaminergics commonly used include prochlorperazine, promethazine, and metoclopramide. These agents have wide dosing ranges and may be started at the lowest dosage and increased as needed for symptom control. The 5-HT3 receptors are used along with these drugs for chemotherapy-induced nausea and vomiting. For the anticholinergics agents, they seem to be most effective in cases of motion sickness or vertigo. Similar to the antidopaminergic drugs, these agents have a wide dosing range and allow for dose modification and symptom control. Scopolamine is best used as a transdermal patch for motion sickness. It also can be used in the oncology patient in whom rectal and oral routes are contraindicated. The NK1 receptors, these drugs are highly effective for preventing nausea and vomiting with certain chemotherapy agents. It's a relatively new product and hopefully will be useful. The 5-HT receptor antagonists, although most chemotherapeutic agents have a emetogenic potential, the use of premedication with 5-HT3 receptor antagonists significantly decrease the nausea and vomiting experience during and after administration. For chemotherapy-induced 5-HT3 receptor antagonists used alone or in combination with dexamethasone and other agents are the drugs of choice. They are also effective for postoperative nausea and vomiting. Also been shown that the serotonin released by the enterochromatin cells of the GI tract is the primary neurotransmitter responsible for chemotherapy-induced emesis. They have a favorable toxicity profile but are considerably more expensive than the antiemetics. The most common agents in this class is Zofran and is now available in generic forms. For patient variables, the geriatric patients, the elderly may require dose reduction and close monitoring because of the increase in adverse effects in this population. You need to rest the bowel by drinking only clear liquids for 8 to 12 hours. This can be the most helpful. It's important to stay hydrated, but water may trigger nausea and more vomiting, so electrolyte drinks would be best. The use of relaxation techniques with cancer patients has been effective in decreasing nausea and vomiting. For pediatric patients, the use of antiemetics is discouraged in cases of uncomplicated vomiting. Anticholinergic antihistamines may cause hallucinations, convulsions, or death. Mental alertness may be diminished, can produce excitation. In combination with viral illness, the risk of patients developing Reye syndromes may be increased with the use of these medications. Dopaminergics increase the risk of extrapyramidal symptoms and may occur when these drugs are used. Children with acute illness such as chickenpox, influenza, and others are more susceptible than adults to the neuromuscular adverse effects of these drugs. Do not give any antiemetic drug to children younger than 12 years of age except for promethazine and dimenohydrinate. Do not use in children younger than 2 years of age. Zofran has been approved in use for older than 4 years of age. Data is not available for use in children younger than 4 years of age. However, in the recently there's been a question about the safety of its use as well. For pregnancy and lactation, none of the antiemetic drugs should be used for nausea and vomiting during pregnancy unless such usage has been approved by the obstetrician. However, Zofran has been shown off-label to be safe for hyperemesis gravidum. However, recently there's been some evidence showing that this is in question. Nursing mothers should not be using these products. Phenergan and Reglan are commonly used during pregnancy. Patient education. These drugs may have a severe sedative effect. Patients should not drive or operate dangerous equipment and should use caution while driving or performing other tasks that require concentration. Alcohol and other CNS depressants should be avoided. Adequate dosing before riding in a vehicle must be ensured for the prevention of motion sickness. Antidopaminergic agents may exacerbate pre-existing psychiatric conditions, so you need to assess for this. And constipation may be severe with the antidopaminergic phenothiazines. Patients should be alerted to report any problems. And finally, males may experience urinary retention with these products. Next, we're going to talk about medications for irritable bowel syndrome and other gastrointestinal problems. Irritable bowel syndrome, antispasmodic agents such as Bentyl, Levocin are used primarily to treat patients with IBS and other functional GI disorders. A large number of antispasmodics are available on the market, but they are not often used. The two most common antispasmodic drugs are the Bentyl and the Levocin. Drug overview: the antispasmodics, anticholinergics, diclopamine hydrochloride, and hycosamine sulfate. The 5-HT receptor antagonists, Lotrinex, GI stimulants, prokinetic agents include metoclopramide, and prostaglandins are included in this drug class. For ulcerative colitis treatment, mesalamine and sulfasalazine are the most common drugs used. Locally acting agents, simethicone for gas, and gallstone stabilizing agents include urusdiol. So antispasmodic, anticholinergic agents are known as the antimucineric drugs. The mucineric nervous system is a subcategory of the anticholinergic nervous system. The other subcategory, the nicotinic nervous system, is seldom involved in drug actions. Anticholinergic agents decrease motility, relax smooth muscle tone in the GI tract, and decrease secretions. Antispasmodics decrease GI motility by relaxing smooth muscle tone. These medications have anticholinergic properties, thus they compete with acetylcholine for receptors at prostaglandinic fibers of the parasympathetic nervous system. Diclopamine has indirect and direct effects on the smooth muscle of the GI tract. It indirectly blocks acetylcholine receptor sites and directly antagonizes bradykinin and histamine in GI tract smooth muscle. Both of these actions help to relieve smooth muscle spasms. Hycosamine, a belladonna alkaloid, inhibits the muscarinic actions of acetylcholine at postganglionic parasympathetic neuroeffector sites, including smooth muscle secretory glands and CNS sites. Thus, this drug has an effect on peripheral cholinergic receptors present in the smooth muscle of the GI tract. Specific anticholinergic responses are dose-related. Low doses inhibit salivary and bronchial secretions and sweating. Next, pupil dilation and accommodation is affected, and heart rate is increased. Higher doses decrease motility in GI and urinary tracts, and then inhibit gastric acid. IBS treatment principles: antidepressants, particularly the TCAs, 5-HT3, and misoprostol have been found to be helpful in some patients. For the antidepressants, the tricyclics and the SSRIs have been shown to reduce symptoms. It's not clear whether this is a separate effect from the antidepressant effect. However, it's been found to be helpful. Smooth muscle relaxants have been noted to improve symptoms. Psyllium fiber, certain antispasmodics, and peppermint oil have also been found to be effective. A trade-off occurs between benefits and harms of all medications. And the 5-HT3 receptor antagonist, Lotrinex, has improved symptoms in women with diarrhea-predominant IBS, and has also increased constipation. It may be associated with ischemic colitis, so you need to use this drug with caution. The cardinal points of treatment pharmacology is based on severity and targeted at specific symptoms. All patients with alternating constipation and diarrhea, they need to increase the dietary fiber to 25 grams per day. Pain needs to be controlled with antispasmodics such as anticholinergic medications for short-term and TCAs for long-term. Diarrhea can be controlled with loperamide for short-term, often used for breakthrough diarrhea, and antidepressants, TCAs, for long-term use. Aldosterone, ordered by a GI specialist, can be used if the patient is resistant to all other medications. However, this needs to be used with caution. For the constipation aspect, they need to increase fiber and may need to use laxatives. Treatment of patients with IBS begins with patient education. The patient must be reassured that there is no organic cause for their symptoms. Teach that this is a chronic condition and that it will not lead to an organic problem. Diet with adequate fiber is the cornerstone of treatment. Amounts of fiber and fluid usually have to be increased. Fiber should be increased gradually to avoid bloating. The patient should drink 6 to 8 glasses of water a day. The patient should identify and eliminate foods that cause symptoms. Foods that commonly cause problems include raw fruits and vegetables, high-fat foods, beverages such as carbonated beverages, coffee and other forms of caffeine, red wine and beer, and artificial sweeteners such as fructose and sorbitol. Exclude lactose intolerance. Other important lifestyle changes include good bowel habits and exercise. The best exercise is usually regular walking. Treatment for patients with IBS varies with the severity and the type of presenting symptoms, which usually occur as diarrhea or constipation. Patients who are experiencing symptoms that become lifestyle limiting should be prescribed medication on a short-term basis and should be advised to modify diet and behavior and participate in psychotherapy. Some of the symptoms include cramping, abdominal pain, antispasmodic, anticholinergic medication can be used as needed when symptoms are present shortly after a meal. Abdominal pain, frequent or severe. Tricyclic antidepressants can be used. For constipation, increased dietary fiber and laxatives. For diarrhea, antidiarrheals such as Imodium, loperamide. For severe, aldosterone for females only may be considered. However, this needs to be monitored closely. Painful symptoms of diarrhea, you may prescribe the TCAs. For painful symptoms and of constipation, There's some conflicting efficacy of whether SSRIs are useful. Simethicone can be used for problems with gas, including explosive bowel movements, belching, or flatus. And lubiprostone and polyethylene glycol also can be used for irritable bowel syndrome. Antidepressants often are used over the long term to treat the patient with IBS and associated psychological symptoms. TCAs have been used extensively. Through their effects on neurotransmitters, they have an effect against abdominal pain. A common side effect, however, is constipation, which makes them most useful in patients with diarrhea. SSRIs are used clinically, but have shown inconsistent results. Paroxetine, such as Paxil, has been shown to be effective in improving bowel regularity, but not in affecting pain. The other SSRIs do not have the mild anticholinergic effect as Paxil does, and they may be more useful, appropriate in patients with constipation. For patients' variables, geriatric patients, lower doses of antispasmodics should be prescribed to geriatric patients because this population may react with increased adverse effects such as agitation, excitement, confusion, or delusions. For pediatric patients, safety and efficacy is not established. Icosapine has been used in infant colic. Diclofenac is contraindicated in infants younger than 6 months of age. For pregnancy and lactation, diclofenac and aldosterone are category B. Icosapine is category C. How do we monitor these patients? Monitor for therapeutic response. The patient should be able to report fewer episodes of abdominal cramping and less diarrhea and constipation. Monitor for anticholinergic effects. Evaluate for increased heart rate and blood pressure, dry mouth, constipation, blurred vision, or urinary retention. For patient education, antispasmodics, they need to refrain from activities that require mental alertness when taking these medications. They need to stay out of hot and humid environments when taking these medications. They should take these medications 30 to 60 minutes before their meals, and notify their provider of any side effects, especially eye pain, rash, or flushing. Gum or sugarless hard candy may be used to relieve dry mouth.